I'll be talking about incoordinate uterine actions. So this is a very important topic. So we'll cover in it the definition of abnormal uterine action, types of abnormal uterine action, the etiology of abnormal uterine action, then the rest of the types like incoordinate uterine actions, clinical picture, spastic lower segment, constriction ring, cervical dystocia, generalized tonic contractions, and conclusion. So first of all, we'll discuss about abnormal uterine action. What is abnormal uterine action? As the name itself suggests, that any deviation in the normal pattern of uterine action in the course of labor, in the full course of labor, that is referred to as abnormal uterine action. So we'll do the definition. So any deviation of the normal pattern of uterine contractions affecting the course of labor is designated as disordered or abnormal uterine action, as I've already told you. Then there's the types of abnormal uterine action. In the types, it is further divided into normal polarity or abnormal polarity. So normal polarity is further divided into hypertonic dysfunction and hypotonic dysfunction. So here is a little misprinting. That is hypotonic dysfunction under it uterine inertia. So we'll discuss about hypertonic dysfunction. In this, there is excessive contraction. If there is obstruction, then further it is divided as tonic uterine contraction and retraction. That is also known as Bandel's ring. And if there is no obstruction, then it is divided into. Then it is not divided. Then under it, that is precipitate labor. Then we'll discuss abnormal polarity. In abnormal polarity, it means incoordinate uterine action, which is our topic for today. So it is further divided into 6 categories: spastic lower segment, colicky uterus, asymmetric uterine contraction, constriction ring, generalized tonic contraction, and cervical dystocia. So first is the etiology of the topic. So etiology is mostly unknown. There is no known etiology mostly of this abnormal uterine action. Second is psychological influence. See, fear that affects us most. So the fear can also be a cause for at the time of labor. So fear can also be a cause for abnormal uterine actions. Then the other is the condition, obstetric conditions, that is disproportion or malpresentation or malposition. So malpresentation and malposition is all like breech presentation is malpresentation, and occipito-posterior position, that is malposition. So this can cause abnormal uterine action than the perineum. So there is always more resistance in first pregnancy, that is the primary bladder is mostly affected. Then full bladder. If the bladder is full, then it can also cause abnormal uterine action, because when the bladder is full, it exerts pressure. It exerts pressure on the uterus. So as a result, the normal pattern of uterine contractions is affected. Then it is common in elderly primary gravida than in young primary gravida. Then the maturity of the pregnancy. Failure of the formation of lower uterine segment can also be a cause for the abnormal uterine actions. Then if the uterus is overdistended, like in multiple pregnancy or in polyhydramnios. So these all are the etiological factors that can cause abnormal uterine actions. So then we'll discuss about the incoordinate uterine action. So incoordinate uterine action, this is usually appears in the active stage of labor, and so the hypertonic state of the uterus arises from any of the conditions such as spastic lower segment or any of these which are known as incoordinate uterine action, conditions which are under it. So we'll discuss them one by one later. First, in incoordinate uterine action, what happens is the duration and frequency of the contractions increases. So when this frequency duration increases, then it also, as a result, what it does, it causes a rise in baseline tone, and thereby what happens is the intervillous spaces of placenta, it does not get enough circulation. So the circulation is diminished in the placenta intervillous space because of the increased frequency and duration of the uterine contraction cause rise in baseline tone. So it diminishes the circulation in the placenta intervillous spaces. As a result, when the circulation diminishes in intervillous spaces of placenta, as a result, what will happen? It will result in fetal hypoxia. If this, obviously, if the circulation is decreased, what it will affect the fetus, and this will result in fetal hypoxia in labor. And on CTG, we can clearly see when if the CTG is also turned on by the labor in the labor. So, what we will see, the FHR fetal heart rate shows reduced variability and late deceleration. So then during the labor period, we often give oxytocin to the mother. So that causes uterine hyperstimulation due to oxytocin occurs, and what will happen if the uterine hyperstimulation is taking place? Then what will happen? Then fetal distress will occur, and fetal distress occur. Then also we have fetal tachycardia. So uterine hyperstimulation due to oxytocin are often associated with fetal tachycardia due to fetal stress. So this was about the uterine incoordinate uterine action. So under this we'll study about some conditions. So first is spastic lower segment. Spastic lower segment is more common in primary gravida, and it is characterized by labor is prolonged. Okay, the period of labor is prolonged than the normal, and then the uterine contractions are irregular and more painful. So mostly we know that in true labor, the uterine contractions are regular. The pains are regular. So in this particular segment, the uterine contractions are irregular and more painful with the lower back pain. Okay, the pain is felt before and throughout the contraction with marked low backache, often in posterior position. So we've already studied that in the causes and etiological factors of that malpositions and malpresentations are also a major cause for abnormal uterine action. So in this, if the position is posterior, then what will happen? The lower back pain will also occur with irregular contractions and more pain. Then high resting intrauterine pressure in between uterine contraction detected by topography. So when we do topography, what will happen? We detect high resting intrauterine pressure. Okay, that is in between the uterine contraction, that is high. The pressure in between the uterine contractions, that is high, when being detected by topography. Okay, the normal value is 5 to 10 mmHg, and it will be higher than this. Then the cervical dilatation will be slow. Okay, if the we already know that cervical dilatation occurs as 1 centimeter, 2 centimeter, 3 centimeter slowly, and when it is fully dilated, it is 10 centimeters. You can see here in the image. So it is 1 centimeter, it is so small, 2 centimeters, then it will increase gradually, and when it is fully dilated, it is 10 centimeter at full dilatation. So the cervical dilatation will be slow with this. Then premature rupture of membranes is also there, and fetal at maternal distress will also be there. So these are all the characteristics of spastic growth segment. Then uterine contraction. What will happen to the uterine contraction? First is the fundal dominance. If fundal dominance is lacking, so if the fundal dominance is lacking, then often there is reverse polarity. So the polar, that is the upper segment and lower segment, they have confusion. So fundal dominance is lacking, then there will be reverse polarity. The pacemakers do not work in rhythm. Pacemakers are the pacemakers are what the things that from where the contractions originate. Then the lower segment contractions are stronger. Lower segment contractions will be stronger, and inadequate relaxation in between contractions that we already discussed. That is high resting temperature, high resting intrauterine pressure in between the uterine contractions detected by topography. So that will be high. So here we can see inadequate relaxation in between contractions will be there, and the basal tone is raised above the critical level of 20 mmHg. So that is basal tone we already studied in the. So here in incoordinate uterine actions, where we can see we have already talked about that increased frequency and duration of uterine contraction cause rise in baseline load. So same thing applies here. So it will be above the critical level of 20 mmHg. Next is the diagnosis. So how will diagnose it? So there are evidence of dehydration and ketoacidosis. Okay, the patient will be having unbearable pain referred to the back. So the backache will be there, and if there are evidences of dehydration and ketoacidosis, you can doubt it for spastic low. Then the bladder is frequently distended, and often there is retention of urine, distension of stomach, and bowels are visible. Then, if these things are there, then you can also down for this fasting flow cycle. Then are the premature attempts to bear down because the bladder is full or she is having distension. Then have urge, she will have urge to bear down. Then are the abdominal palpation, that is obstructed ribs when we do. Then there is distension of the stomach. Then we cannot feel the fetal parts. That is very difficult. Then by the abdominal palpation, we can also see if the uterus is tender, and gentle manipulation will excite if it excites hardening of the uterus with pain. And the palpation of the two parts is difficult, that we have already told you. So next is fetal distress appears early. Then internal examination. If we do internal examination, what we see that the cervix, which is thick, edematous, hangs loosely like a curtain. Okay, and not well applied to the presenting part. So the cervix that is thick and edematous hangs loosely like a curtain, not well applied to the presenting part of the fetus. Then inappropriate dilatation of the cervix. Okay, it will be slow. Dilatation will be slow. So these all are the diagnosis. And then next is the absence of membrane in some conditions. The membrane can be absent, or we have seen in the where we see premature rupture of membrane. If the membranes are ruptured prematurely, then there will be absence of membranes. Then there will be absence of membranes while doing the internal examination. Then meconium stained lacquer and gangrene will be there. Okay, if the fetal distress is there, sometimes due to fetal distress, the fetus passes meconium. Then it can cause meconium stained lacquer and gangrene. So this is about the spastic flow segment. Next, we will see the management. So, as there is no case of oxytocin augmentation with this abnormality, cesarean section is done in major cases. And we have already studied that the diagnosis that it has dehydration and ketoacidosis. So, we will correct that by rapid infusion of ringer solution. So, this is the management of spastic flow segment. So, I think we will stop here, and I will make another video of the next one because there is a time limit now I have to do. So we'll discuss rest of the diseases in next video. Thank you, and please like, share, and subscribe to my channel. And if there is any other topic that you want to study, then you can mention it in the comments, and we will see